Okay, so once you're in the Menti, if you could give me a little like or a thumbs up, just so I know that you're here. So last week we talked about diabetes in general, kind of the pathophysiology, specifically with type 1 and type 2, and what that means for patients. Today we're going to dive in a little bit more to how high and low blood sugars affect patients. And then the second Menti is going to be more of insulins, how they work, as well as complications from not controlling your blood sugars. So let's get into it. Here we go. So when we talk about high diabetes, typically the two main effects, right? This hormone isn't being regulated. And what's the hormone that we're talking about here? Insulin, right? And where is it produced from? Pancreas. Where in the pancreas? The beta cells, right? What's the other hormone that pancreas secretes that helps with glucose regulation? Glucagon, right? Glucagon is what to your blood sugar? It helps to increase. It helps the liver to release glycogen or glycogen, so it will help increase your blood glucose levels. All right, so typically what we see is that these hormones aren't being regulated, and your blood sugar either goes too high or it goes too low. So hypo, right? Hypo is low. Usually 70 is kind of our benchmark of where we say is low. Hyper means high. Usually when we're talking about hyperglycemia, we're talking about 250 or higher. Every patient is different, right? We might have a little bit tighter control for some patients. Okay, we don't want you to go over 200. Their symptoms, we're going to go over a little bit more in depth, but oftentimes the symptoms overlap. They could be very similar for these. So sometimes they call hypoglycemia an insulin reaction. That's kind of an older term, but you might see some of your older patients say that. And we'll get into what that means in a little bit. So hyperglycemia, so here it's just saying over 126 is just higher than you want it to be. So causes, why would our blood sugar go high? So, right, we eat too much, maybe that's part of it. Stress, our cortisol levels, we talked about in our endocrine class a couple of weeks ago, how that will drive your blood sugar levels up. If you're sick, again, that stress on your body will increase your blood sugar levels. Or if you're not taking your medication, right? Type 1 diabetics not taking their insulin, perhaps, or type 2 diabetic, maybe is taking insulin, but maybe also not taking their oral medications as well. So we talked about the 3 Ps. What are the 3 Ps of hyperglycemia? Yeah, polydipsia, which is really thirsty, polyphagia, really hungry, and polyuria, which is you're urinating all the time. And we say those are the classic signs of diabetes, but they really are those the classic signs of hyperglycemia, when your blood sugar is high. So when you have hyperglycemia, your vision can get blurry. When my son was first diagnosed, he did say, he was like, yeah, everything's kind of blurry. Kind of wondering, like, almost like, do you need glasses? And the doctor was like, no, it's going to get better once his blood sugar normalizes and he gets back in stable glucose for a while. That's when you start. It can be, yep, it can be one of the symptoms that people have. You're not always. It won't always be blurry vision. It should go away once it's regular. It might go away, not go away right away, but within, I mean, hopefully, like my son's was within a day, his was back to normal. So you can be fatigued and lethargic. You can have a headache, abdominal pain. You can have ketonuria. What does that mean? Ketones in the urine, right? We're building. Why would our body produce ketones? Yeah, it's breaking down that fat, especially fat and muscle, but especially that fat makes the ketones because the cells are starving. They don't have enough energy, even though they have all that glucose, there's not enough insulin to get that glucose into the cells. Eventually, you can have a comatose state. So how do we treat it? Well, first, before you treat it, you have to check it, right? Make sure we know what the blood sugar is, right? Because high blood sugar or low blood sugar for that matter, they can mimic a lot of other diseases like neurological processes, or maybe somebody who is on drugs, right? That's one of my biggest things with my son. He refuses to wear a medical alert bracelet. And I keep telling him, I'm like, you're a 17-year-old knucklehead. If you're acting wonkadoodle because your blood sugars are high or low, they're not going to think of diabetes. They're going to think you're high. And he's just like, it's fine, mom. But really, it could, right? Our blood sugars, when they're wonky, can mimic other things. So patient teaching tip, right? We always want to make sure we educate them. We can't force them to wear a medical alert bracelet, but we really do want to educate them to wear one. If their blood sugar is high, the first treatment's usually going to be to give them insulin if it's super high, right? If somebody's newly diagnosed with diabetes, do you remember what we usually start with for those patients? We start them with oral medication. But if their blood sugar is really high and it's out of control, we might need to go ahead and give them insulin just to get them back to a level state. Especially like our type 2 diabetics, we want to get them level, and then we're just going to send them home or send them on their way with their oral hypoglycemics. We want to see if there's ketones in their urine, because that's going to let us know how much it's affecting their body. We want to see what the cause is, right? Why do they not, did they run out of insulin? Are they sick? Did their grandma just pass away? What's happening that cause their blood sugars to go up? We always tell patients at home, if your blood sugar is over 180, this is roundabout, right? Every provider might say a little bit different number, but 180 is a good number. If your blood sugar is high for over 2 days and you're treating it, you're doing the things that you're supposed to do. One of my first things I tell my son is go drink a big glass of water, right? All the extra water sometimes can help flush the glucose and help lower the blood sugar levels. But if it's not coming down, you need to call your provider because you might need some extra treatment. And anytime our diabetics start vomiting, that's when we get really concerned. Actually, it's funny, this weekend, I have a friend of mine, her son is also a type 1 diabetic. Really interesting, very similar presentation where he got a cold and started to lose weight, not feel good, all these issues, and he ended up being diabetic. Well, he ran out of insulin this weekend, and they go to Costco. Do you guys know when Costco's pharmacy is open? Not on the weekends. So they were out of insulin, and she called me because she goes, we're up in Seattle, we're on our way back down here, but we have no insulin. His blood sugar is in the 600s and he just started vomiting. And so because we're friends, we're in our little diabetic community, I said, I've got insulin, where do you want me to meet you? Like, anyway, so we traded insulin, right? I gave her some insulin, she traded me back some later once they were able to fill it. But he was close to having to go to the hospital because we know once they start vomiting, that's where you're like, okay, this is getting kind of scary. So she was able to get his blood sugar under control pretty quickly. Like that evening when I checked with her, his blood sugar was back in the 200s. He was doing so much better. But if his blood sugars continued to remain high, if he continued to vomit, that's when they need to go to the hospital, right? So vomiting, that's always a symptom of something wrong. Or even if it's a digestive issue, maybe it wasn't a symptom of the blood sugar being high. Maybe it was they have a stomach bug. That's still going to trigger things where it makes it really hard to control your blood sugars. And you want to call your provider and just make sure there's nothing you need to do. Okay, so let's do a little activity cue. You guys are home health nurses and you want to reinforce care to a newly diagnosed type 1 diabetic. When you come to the home, you find him lethargic, unable to really answer questions, and he's asking for water. So turn to the person next to you, and just for about 60 seconds, let's talk. What do we do? What are our next steps? All right, let's see what F.A. Davis recommends. Oh, I clicked off again. So check the blood sugar, right? first thing, let's see, where is his blood sugar at? We also want to check the urine for ketones as well. We want to give him water. We know that increasing that hydration is going to help lower the blood sugar. We're probably going to call either the RN or the healthcare provider to get some orders to see what we need to do. And those orders are probably going to be to administer some extra insulin as one of our first steps. We know that lethargy and thirst are a sign of high blood sugar. Because he's type 1, that's why he's risk of having the ketones in his urine. And we already talked about this. So how do you guys feel about kind of identifying those things? Thumbs up, thumbs down, in the middle, most of them. I see a lot of thumbs up or not. Okay, so management in type 1, they typically don't do oral medication. It's pretty much insulin because remember, it's that autoimmune component that has shut off those beta cells of the pancreas. They just don't make insulin. So you just have to give insulin to replace it. Exercise can help, right? If you are exercising, it actually does benefit you overall. Like it really helps type 2 diabetes with our lifestyle, but it can help or does help type 1 overall, increasing your heart health. Actually, fun fact, because we talked about cardio this year or this term, my son's cholesterol is a little bit high. Not high that we'd normally be worried about it, but a little bit high. And his endocrine doctor said, okay, we're going to check it next time he comes in because we might want to start statins, which are cholesterol lowering medications. And I was really surprised. I was like, really, that's kind of, that level doesn't seem to be concerning right now. And he said, you know, you're right. But with diabetic patients, we know there's such a close connection with heart disease and diabetes that we have a lower threshold for letting that cholesterol get high. So I'm like, oh my gosh, my son's not even 18 and I might start him on statins. But if that's what it takes to keep his heart healthy, you know, because he has this disease that doesn't have a cure. All right. So I'll keep you guys updated. I'll let you know where his cholesterol is next time. We'll see how he is. But type 1, they have to have insulin. So hypoglycemia. Now we're going to turn to hypoglycemia. So quick question. If you're taking care of somebody with low blood sugar, what glucose level are we kind of expecting here? What glucose level means low blood sugar? All right, nice job, you guys. So yes, generally less than 70. I will say that if you are used to a very high level, like my son was probably used to a pretty high level of blood sugar for a while. He started feeling hypoglycemic around 200, 175. I remember there's a diabetic educator in the hospital that we talked to us, and she was trying to teach them about insulin and how to administer it. And I could just tell something was off with him. I was like, nope, there's something wrong. And I finally just interrupted. I was like, I'm sorry, please do not. I'm like, Justin, like, do you feel okay? He goes, no, I don't feel good. I can shake. I just don't, I can't think straight. So I checked his blood sugar and it was around, I think 175, 180, which that's actually high, right? But he was used to it being so high. As it was getting to more of a normal level, he actually was having signs of hypoglycemia. We want to educate our patients that that's okay, but we don't want to see them down too drastic, right? Kind of like when we're lowering our blood pressure for patients who've had it really elevated for a while. For him, if he's starting to have signs of hypoglycemia, we're just going to keep him there for a little bit. And after a day or so, we're going to try to keep trending him down because they'll start having their bodies reacting. They're going, whoa, 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 whoa. We're like, we've had all of this and now we don't have any. What's happening? So just know, especially if they're type 2 diabetics, maybe have been going on for a very long time. It's pretty high blood sugar levels. They might experience hypoglycemia at some pretty high levels. And we just want to tell them, hey, we're still working on we're going to get you back down to a normal level. All right, so why do we have low blood sugars, right? You might have taken too much insulin. Maybe we were exercising and we hadn't had a snack or something like that. Really important, diabetics, regardless if you're type 1 or type 2, especially type 1 though, they need to make sure they think about when they're going to exercise. They're going to go for a run, they're going to go play basketball, they're going to do something. We want to make sure you have probably a little snack beforehand. Don't carry a snack with you. because that exercise is going to be depleting the glucose that you have. Or maybe they're just not eating enough food in general. I've had some times where my son has kind of had a combination of these, where some food looks good, and so he'll take insulin based on how much food he has. But then halfway through, he's like, this really is not as good as I thought it was. So he took too much insulin and he didn't really eat that much. And then he's like, but I still want to go play basketball. And I'm like, oh, no. I'm like, drink this Gatorade at least and keep drinking it, right? Do something so we can maintain your blood sugars. So symptoms, this neuroglycopenia, I don't know, I've never seen that word other than really here. It's just where you have those neurological symptoms. So you have a headache, confusion, irritability. That seizures and coma, those are kind of at the very end. Those are rare. Usually we can prevent that. That's very uncommon. Headache, hunger, shaky. I think I told you guys this before. One of my instructors told me a long time ago, cold and clammy, you need some candy. Hot and dry, your sugar is high. So if you look at your patients, if they're cold, meaning they're just kind of cool and they're a little bit sweaty, cold and clammy, they need some candy. Hot, they're hot, but their skin is dry, hot and dry, the sugar is high. That's a general rule of thumb. It's not always true, but in my experience, it's a pretty good rule of thumb. They also can have some visual changes too. I remember my son, his blood sugar was low and he was trying to do schoolwork on his computer. And he was like, and it was early when he was first diagnosed. And we treated the blood sugar, it was coming back up. And he was like, Mom, I just can't focus on this. And I was like, well, what's going on? He goes, okay. And he picks up his computer and he was like, this screen, like this screen right here. He was like, that's all that I can really see. I have about a window of this much in front of me, except for it's doing this. So even though we treated his blood sugar and it was coming back up, his vision was still like still recovering a little bit. And so I have learned if his blood sugar is low, he gets a pass. I'm like, okay, let's do something else. Let's figure it out. But you're probably not going to be able to go to the dosage test or do something where it requires a higher level of thinking, right? So treating it, usually you want to give 15 to 20 grams of fast-acting carbohydrates. What's an example of a fast-acting carbohydrate? Hard pasta could be juice. Yeah, so you want to think what is really sugary that's going to break down quickly. Juice is really good because it's got a lot of glucose in it, or fructose, but it's sugar. And because of the liquid, it's going to break down and absorb really quickly in your stomach, right? Why wouldn't we want to give him being my son, but whoever, why wouldn't we want to give them something that has a lot of fiber or proteins or fats yet? Right, it'll slow the digestive process and it will take longer for that glucose to get up in the system. Now, we're going to check the blood sugar again in about 15 minutes. And as long as we're coming back up, we're looking good, that's when we go ahead and follow up with more proteins, with some fats, some fibers, what do they call it? The dense carbohydrates that have more fiber in them, complex carbohydrates, that's what it is. So those take longer to break down, which means they're going to help maintain your glucose levels. Because if you think about when you eat something, if it's just sugar, it spikes your blood sugar up really quick, but then it also comes back down pretty quick too, because it's not very long acting. When you have things like proteins, that will bring your blood sugar up a little bit slower and then come down a little bit more. Fats, even more so. What we've seen with my son, pizza is like the worst because it has a lot of fat, he likes meat pizza, so it has a lot of protein in it, but it also has a lot of carbohydrates in it. So his blood sugar will go up, pretty high, pretty quick. But then it stays really high because of all the fat and all the protein in it. So even though he may be bolus for all the carbohydrates that he was going to eat, usually he has to bolus or give some more insulin later to help cover all those fat and proteins. So whenever we're treating low blood sugar, we want to make sure we always follow it up with some fats, some proteins, some complex carbohydrates, something to maintain the blood sugars, especially if it's like my son who took all that insulin but didn't eat, right? We're going to talk about insulin timelines a little bit later, well, how long the insulin lasts. You know, with his insulin, if it's in his system for the next several hours, well, that Gatorade he just drank isn't going to last very long, right? It's going to keep his blood sugar high for a little bit, but then that insulin's going to be keeping him working. You've got to keep something in his system. If it's longer than a half hour to a meal snack. One thing I want to make sure, because I don't know if we really talk about it, but okay, I'm going to put a pin in glucagon. If I don't come back to glucagon, remind me, all right? So fast sugars, we talked about this. So juice, regular soda, right? Not diet. Box of raisins. I've never seen anybody who wants raisins when their blood sugar is low. Glucose tablets. Those are disgusting. Some people actually carry them. I think because they last for a long time. You can throw them in your purse or throw a few in your wallet or car, and they're there. I say, do something that you like. Right? If you like M&Ms, or like I said, maybe Skittles, some candy, like those little, like, especially coming after Halloween, all those little snack sizes, those are perfect. And I found when my son gets a little belligerent, when his blood sugar is low, he's much more likely to eat or drink something that he likes than something that he doesn't like. So it's always nice to know your patient's preferences. It's fun. Okay. Here, let's talk about glucagon here really quick. So glucagon, we talked about how our pancreas produces glucagon. It stimulates the liver to produce glycogen, I believe I'm saying that right, and it helps bring up your blood sugars. We can give glucagon to our patients to stimulate this. If we're not, especially if their pancreas is kind of faulty, it maybe isn't producing enough glucagon anyway. That might be part of the problem. So we have glucagon that we have, they're almost like EpiPens that you give to patients. So in the hospital or in a clinic, if your patient's blood sugar is low and they're not able to take orals, right? They are out, they are unconscious, and their blood sugar is too low. We're not going to pour juice down their throat. That's just going to give them pneumonia. If they're somewhat coherent, you know what a next step would be between eating or drinking and glucagon? What's that? So if they can't drink something well, but they're not totally unconscious, before we give them glucagon, they know we can maybe try to do dextrose, or I like to say subbuccal, under your tongue. Remember, we talked about it with nitroglycerin, that we have a lot of vascularity under our tongue. And so a lot of times they'll say put honey or sugar, something with a lot of glucose under the tongue, and that will absorb. And then you don't have to, it's not like we're not pouring things down their throat they're going to choke on, if that makes sense. But next up would be glucagon. I love that they also have a glucagon that's intranasal now. And so a lot of people, especially this makes me feel more comfortable with my son, that some people don't feel comfortable giving a IM injection, right? Even if it's kind of like an EpiPen, a lot of times they're like, oh, this feels too weird. Now they have, it's like Narcan too, right? It's very similar to Narcan, it's just a nasal injection, and it stimulates that release of the glucose into the system. So that's going to be our emergency medicine for low blood sugars. So we have a patient who's at home with type 1, and her husband finds her unconscious, can't put anything in her mouth, she's totally out. So he gives her glucagon, 0.5 milligrams, a normal dose, subcutaneously. All right, well, we're going to forget about the route. She awakens in 5 minutes. So why should her husband offer her a complex carbohydrate snack as soon as possible? We're going to decrease the possibility of nausea and vomiting, to stimulate her appetite, to decrease the amount of glycogen in her system, or to restore liver and glycogen and prevent secondary hypoglycemia. You guys got it. We're trying to restore all of the glycogen and then keep her blood sugars up in the meantime. All right, so diabetic ketoacidosis. We talked about this a bit last week. The type 1 diabetics are pretty much what you're going to see who have this. Usually it's because of stress or illness or non-compliance. I think we're going to see the non-compliance less and less because we have a lot of advances in managing diabetes that we didn't have. And so with those advances like insulin pumps or continuous glucose monitors people wear, people aren't poking themselves as much, right? They can just wear a device that they only have to change every few days. It really helps them to be more compliant with whatever their regimen is. And so we're not seeing non-compliance as much. With non-compliance, I will say my sister had a best friend and well, she's still very good friends with. And there were times during high school, my friend would say, oh, here, let me check your blood sugar. Like, I just want to see what you are. And then she would check our blood sugar and it would be normal. And she would go, oh, good. My mom will love seeing this later. Because she tricked us and she would check our blood sugar, but then she would show that to her mom later and be like, look, see, you can see that was my blood sugar. I'm good. Because her mom wouldn't let her go do certain things if her blood sugar is out of control. You know, a few decades later, she now has retinopathy and she's blind in one eye. She has a lot of issues because she really had a lot of trouble with controlling her glucose, some choices, a lot of that. And she kind of regrets it now, you know, she's like, man, I wish I would have done differently then. Pathophysiology with the DKA. So if you don't have enough insulin, your cells are starving and your fat breaks down. I feel like you guys all have a pretty good grasp on this. The byproduct of the fat breakdown is the ketones, and the ketones are really acidic, causing that acid-base imbalance. So flu-like symptoms, right? You often will have those signs of hyperglycemia because that's what's happening. Our blood sugar is really high. So you've got the 3 Ps. You also start to have these small respirations where you have these big breaths. Okay, going all the way back to electrolytes imbalances. When we breathe out, what are we exhaling? Carbon dioxide. What does that do for our acid-base balance? Right? It's exhaling some of that acidicness or acid, essentially the carbon dioxide. It's helping to restore the balance. One time my son's blood sugars were really high and we had run out of insulin incidentally and we were heading home and I started to notice his breathing patterns changing. And I started to freak out because I was like, I know what this means. And my husband was like, I don't know what you're talking about. I'm like, see how he's breathing. Tell his body is trying to compensate for what's happening inside, which I probably sounded like a crazy person because he had no idea what I was talking about. But we know these things. And so sometimes it makes it a little bit different. There's going to be times, guys, when you're out clinical practice and something just really bothers you. I noticed with myself during the situation, something was bothering me and it took a minute for me to pinpoint that it was my son's breathing patterns, but I knew that something was wrong. So when you're out working, when something's bothering you, don't dismiss it, investigate it, figure out what it is, because I think nurses have this spidey sense where sometimes they're like, I'm clocking something, there's something that doesn't make sense, it's not right, I can't quite put a finger on it right now. Follow that, because a lot of times with our training and what we know, there's something happening that it's in our periphery that we're picking up on it that's maybe not right in our face. So follow your nursing spidey sense. They also start to have fruity breath. There's a fruity odor to those ketones in their breath. They have electrolyte imbalances, especially with potassium. Potassium and insulin have a very strong correlation in and out of the cells. So there's a lot of glucose out of the cells. There's going to be a lot of potassium out of the cells as well. They're going to be very dehydrated. They can enter a coma and can eventually die if it is too high for too long. So what are we going to do? We're going to give them IV fluids, right? Before we get to DKA, we're going to really push oral fluids for hydration. Once they're in DKA, we're still going to probably push clear fluids, but we're also going to give them IV fluids. We're probably also going to have them on insulin IV, on an IV drip. Anybody know what type of insulin we give in an IV? Regular insulin. regular insulin is the only insulin that you will ever give IV. That's in production now. Who knows? Maybe in 5 years or so, there'll be another insulin. But for the last, as far as I've been a nurse and longer, that is the only insulin that you're ever going to give IV. You're going to be monitoring their glucose a lot. And like I said about the electrolyte balances, you're going to be monitoring those electrolytes and replacing them. So prevention, how do we keep people out of it? Well, first, we're going to try to keep their blood sugar in check, right? But if it gets too elevated, we're going to be evaluating for ketones. Whenever my son's blood sugar has been high for a little bit, I'm like, hey, you need to go check your ketones. And he knows, like, he has the ketone strips. So it's just like a urine dipstick. And you just dip it in and you look at the thing to see how many ketones you have there. And sometimes he will have ketones based on how much is there. That's kind of how you treat it. You say, okay, you're high ketones, oh Lord. Usually you have a plan that your provider will give you. It's usually doubling up your insulin, drinking more water, checking it again. A lot of times if it's small to moderate, he'll drink a bunch of water and then hopefully go for a little walk, do some exercise, and that usually helps to bring it down with more insulin. We always want to have careful regulation during stress or illness. Most diabetics, type 1 or type 2, are going to have sick day guidelines. So their provider will teach them, hey, anytime that you're sick, you should know your blood sugars are going to go up. What you normally do for a high blood sugar will probably not work if you are sick or if you're having a lot of stress in your body. So they'll give them things that will say, if you're sick or stressed, this is what you do. You will take, and sometimes it's different for every person. It might be taking twice the amount of insulin. It might be like all these kinds of things. So there's going to be sick day guidelines that they will follow. Usually there's time frames on that. It'll say if for 24 hours you still are having high blood sugars, or if you start having one symptom, you would want to call the doctor right away. What's the one symptom you want to call the doctor right away? Vomiting, right? Remember that nausea and vomiting, that's always going to be really, that's our sign that it's time to call the doctor or go in to get seen. So that's part of that sick day guidelines. No, they won't have them all the time unless they don't have enough insulin in their body. Yeah. So this is a big one. Hyperosmolar, hyperglycemic, non-ketotic syndrome. Aren't you so glad we call this HHNKS instead? But we want to know what it means. So hyperosmolar, right? So the osmolarity, really high, very concentrated. Hyperglycemic, so a lot of blood sugar, a lot of glucose in the blood. Non-ketotic, not producing ketones syndrome. So this is what our patients with type 2 diabetes can experience when their blood sugars are really high for a while, because they don't traditionally produce ketones, because usually they're still producing some or enough insulin to keep them from producing those ketones. So again, it's stress or illness, most common in the elderly, but I think if we see people who are not compliant younger, you can see this as well. So your blood glucose is elevated. You're going to have the 3 Ps because of that. They get profoundly dehydrated. Mostly, I think, because they don't have the ketones. They're still producing insulin. So they don't have as many symptoms. They don't get the nausea and vomiting usually. They just get the 3 Ps and they're like, well, I'm just hungry and thirsty and peeing a lot. High mortality, because a lot of times they don't get help. These patients' blood sugars can be up to 1,000 or 1,500. So high, right? And they still don't have these crazy symptoms all the time. They are extremely dehydrated. That's one of the hallmark symptoms, is that you are extremely dehydrated. Your blood sugar is crazy high, but you don't have ketones. So whenever we're looking at a patient, we're like, okay, is this DKA or is it HHNKS? Remember, ketones for diabetic type 1s, no ketones for type 2. Type 1 diabetics, it's usually high, right? Like 600, 700, somewhere in there. HHNKS, That's where you get like up into the 800s, 1000, 1500. They can get crazy high, but because our body's still producing some insulin, they still don't have the same side, the symptoms always. So what do? It's the same treatment as we do for DKA. We hydrate them with IV. We give them insulin. What kind of insulin? Regular insulin. We monitor their glucose and we give them electrolytes. So even though the two are completely different in what can cause it, they're different in their symptoms, the treatment is the same for both. So prevention, SMBG just means self-monitoring of blood glucose. If the glucose is rising, then we tell them, hey, drink some glucose and get that glucose down, or drink fluids, not glucose, drink water or sugar-free things, try to rehydrate. Which patient should be monitored for personal respirations? Is it the patient with type 1 diabetes that's out of control? The patient with new diagnosis of type 2 diabetes? The patient with metabolic syndrome? The patient with gestational diabetes? All right, and it is the type 1 diabetic that's out of control, right? Because usually what is the Kussmaul respirations trying to correct? The acid-base imbalance. Which type of severe high blood sugar causes acid-base imbalance? DKA, right? So you're not typically going to see this with type 2 diabetes. Metabolic syndrome has not developed into diabetes yet. And gestational diabetes typically mimics more of a type 2 diabetes than type 1. All right. I think you guys can tell me this. Why, and you just say it. Why do patients with HH&KS, why don't they have a pH imbalance? Right, that's, I'm hearing a lot of, like, they're not producing ketones. It's those ketones that really cause the acid-base imbalances. All right, so here's a game. So get your phone or your computer up. Is it hypo or hyper? I'm going to give you a sign or symptom, and you tell me, is it high or is it low? So they're hot and thirsty. Hey, nice job. What's the saying? Hot and dry, the sugar is high. Nice. All right, they're shaky and tremorous. Yeah, hypo, it's low. What about cold, clammy skin? Yes, what's the saying? Cold and clammy, need some candy. Yep. Confusion. Now this one's kind of tricky. It can be both, right? Typically, we think hypoglycemia, they're a little confused, they're kind of off. It can be with hyperglycemia as well, especially if it's very high. Agitation and irritability. You guys are both right. So typically we see irritation and irritability with high blood sugars. I noticed when my son has high blood sugars, he is extra cranky. And I'm like, dude, go drink some water and then we'll talk. But you can be kind of irritable and belligerent with some confusion when it's low as well. Slurred speech. So hypo, usually that slurred speech is usually with hypoglycemia. You're all good. What about blurred vision? So this one could be both. Typically, when I say blurred vision, That's with hyperglycemia, it's high. The visual disturbances, like my son was like, he has this one visual thing when his blood sugar was low. That usually you see visual disturbance for the low blood sugars, but who knows? Somebody who can't articulate well, they might say their vision's blurry. Right, but so visual changes with both hypo and hyper. All right, that's the end. All right, so, well, actually, you guys ready for break? Yeah, okay, let's take about a 10-minute break and come back at 20 after this clock. And we're gonna check our blood sugars if you're up for it. I watched this and I didn't know how to respond to it. Maybe this is this. So I'll see you in about 10. Oh, let me get some alcohol.
That was when the hair wasn't. Yeah. 1000%. But here now. Well, for the last time. Way. Way. There you go. Now we've got like, she's crazy hair on the side. Whereas this picture, she didn't have it on the side. Oh, you know, like, but. Yeah, and I'm sorry, that's. I know. The console just maybe. Oh, yeah. You see that that's huge. Like, you did that, so. I don't know.
I'll make a. I'll add. Yeah. Well, okay. I'll add you to the canvas and then this. Yeah, sorry. No.
So ridiculous. That is, it's not wrong. It's not wrong. They're saying that sometimes. Yeah. I'm not, I'm just gonna see.
Yeah.
Heart rate and back again, like that's what. My guess is it's what's true. Right now. He's chilling outside. I don't think that I actually go to you guys I don't care about school. I don't know. Target on Yeah, they figured out. Yeah, I have it on my phone. Yeah, leave your phone with us. Give us a spike in blood sugar.
I know, I was gonna say, if you wanna check your blood sugar before you eat and then after, you're welcome to. Mm. All right, so when you get into the Menti, go ahead and give me a little thumbs up, something, let me know that you've entered. And so with this, we're talking more about insulins, medications, as well as complications. So before we manage diabetes, what do we need to do? Check the blood sugar. You don't have to enter it. We just did a blood sugar check, so it's nice and fresh on our minds, right? But before we manage it, because the signs and symptoms of high and low blood sugars can be similar and overlap, we want to make sure we know what we're treating. Are we trying to increase the sugar or trying to decrease the blood sugar? So self-monitoring of blood glucose, that SMBG, really, I don't know if you'll see that a whole lot. But a lot of times what you'll see is that patients at home, if they are doing finger stick testing like this, they're gonna test before meals, which the abbreviation is AC for before meals, and at HS, hour of sleep. You just wanna make sure they know what their blood sugar is before they go to bed, right? If it's kind of low, we're probably gonna give them a little snack. If it's high, they're probably gonna give a little insulin or something to help keep it under control. We wanna make sure that the patients can analyze that meaning of the results, they know their target range, and they know when to call the provider. We also follow those steps too, but it's important we teach our patients that. So glucometers, this is what we just used. Just a second, I realized I didn't share my screen, I don't think, on my Menti, or hold up. So sorry, guys. Just do that. Okay, maybe nobody will even watch this, but at least this will make sure that you can see, if you're watching, what I'm doing on here. Okay. So here's other types of little home glucometers. At the hospital or in long-term care facilities, you can get a variety. Sometimes they'll have the really big monitors as well. They're just a little more durable than the smaller ones. You also are going to teach your patients to do a glucose diary when they're at home, or they should be following something like this, where the time of day, it'll say, what time is it? What was your glucose when you checked it? And then how much insulin did you give? Or what medication did you take? Did you take your metformin there? Did you take, whatever they're on? It's really important. It's like, where was it here? She was 3:02 at 6 o'clock, but they wrote a little note, ate cake at Betty's party. Oops. Right? We still want our patients to be able to enjoy their life, and eating a slice of cake every once in a while is not going to be throwing them totally off, right? Because you can see she was back to 180 in the evening. We just want to make sure our patients are hanging out really high for a long time. We also have CGM, or continuous glucose monitors. This little guy, this one is called a Dexcom. And this one, it has an insertion thing that you wear it somewhere, anywhere you have subcutaneous tissue. Don't take the peeling off if you don't mind, because otherwise it will get sticky. But if you don't mind passing this around, this is what my son wears. You can see this one here, I think is the Libre is the name. There's a couple of different types. I think with the Libre, you have to hold the sensor or your phone up to it, and then you can see the reading. With the Dexcom, you can, like this lady's wearing a Dexcom, it just transmits to either your phone or the sensor, so you can continually see it. Like with me, I follow my son. And so I can see he is at 146, and I can see that through the night, he was a little bit higher, but he's actually done pretty dang good. He has surgery, that sinus surgery I told you guys about. He's trying to make sure his A1C is in a better level, so he's had motivation to keep his blood sugars a little bit more stable. Okay, so urine testing, remember I told you that they used to go lick, they used to try a little bit of people's urine, aren't we glad we don't do that anymore? But they did develop tests, like little dipsticks, that would just test for glucose to see if that was in glucose in the urine. Now that we have finger stick, we can check serum or blood glucose. They don't usually do glucose in the urine checking anymore, but we do check for ketones in the urine. So we are gonna have our patients learn how to take do urine testing to test for ketones. So medication, insulin could be for type 1 or type 2. Oral hypoglycemics are typically just for type 2. And then there's other injectable medicine. Boop, boop, boop. All right, here's a question for you. Which route can insulin be administered? Select all but apply. So how can we give patients insulin? Oral, inhaled, topical, intravenous, subcutaneous? I don't know, you gotta ask, you gotta answer. I did. I don't know, isn't it interesting? All right, so our answer is subcutaneous, you guys almost all got. Intravenous, right? Which medication, which type of insulin is intravenous? Regular, and it can be inhaled. This video is super cute and kind of gives a little example of inhaled insulin. And this is from the pharmacy company that produces it, so I'm not trying to support their company, just
now
so you
living
know.
with diabetes? Afrezza insulin human inhalation powder is the only inhaled, ultra-rapid-acting mealtime insulin that delivers glucose management in the moment for adults living with type 1 or type 2 diabetes. Please see important safety information, including box warning for Afrezza, at the end of this video. Are you currently injecting insulin, or are you talking to your doctor about the possibility of injecting insulin? Afrezza is a different kind of insulin, and here's how. Everyone needs insulin for their bodies to make use of the energy found in the foods we eat. After a meal, insulin allows sugar to move from the bloodstream into cells to function properly. But people with type 1 diabetes don't make any insulin at all. And people with type 2 diabetes are unable to make enough of their own insulin or have insulin resistance, making it challenging for both to keep their blood sugar at healthy levels all the time. That's where mealtime insulins come in. Mealtime insulins are usually delivered through an injection into an area of your body like your stomach or thigh, and typically require you to time your insulin delivery around your meals to give the insulin time to start working. But Afrezza is designed to work differently. How? Well, Afrezza is delivered by inhaling a dry powder insulin using an oral inhaler and allows you to take your insulin right when food arrives without the need for injection at mealtime. Because Afrezza is inhaled, insulin enters through the large surface area of the lung, which allows for ultra-rapid absorption. In fact, as Afrezza passes through your lungs, insulin is released into your bloodstream in less than 1 minute. Afrezza utilizes Technosphere technology. Technosphere technology provides a unique delivery of medicine to the lungs. The microparticle used in Afrezza consists of 2 main components: human insulin in its most basic form, combined with an inactive ingredient.
Okay, we don't have to go into all of the specifics of this medicine, but I think it's really, I like how it shows how you inhale the insulin and how it goes into your lungs. So going back, the foundations or other classes, depending on where you give medications or how you take them, that determines how fast it's available to you. right? Like we talked about under our tongue, subbuccal, there's a very fast uptake because it's so vascular, it kind of gets right into our blood system. What about we're talking IM versus sub-Q? Which one is absorbed faster?
Or no, intramuscular.
IM, it's more vascular, right? Subcutaneous is a little bit slower. When we give insulin, we give it subcutaneous. That's typically where it goes. We want it to slowly release in the, well, in the fat layer. But like this, I like how it said, you know, a lot of insulins, they don't ever work, even our rapid acting that we'll talk about in a minute, it doesn't happen immediately. It's not like our insulin is that's produced from our pancreas. But when we give things through the like through our airway, it's an inhalation route, they are very rapidly absorbed. And so this insulin that if you're given inhalation is super fast. So this is only like, I like how it said it's just mealtime insulin. So you might still have to take something else with it. You might have to have a long-acting insulin or something else to help control your blood sugars. But as far as with meals, this is a nice option for people. Okay. Click back on. Did it go? Okay. So you have a few different types of action of insulin. We're going to stick with rapid, intermediate, and long-acting insulin. So at your tables, you have examples of each. So anybody want to guess what is a rapid or short-acting insulin?
But you're gonna find it again later.
Right, but on your tables, which kind of insulin? What is the name of the insulin? Anybody identify a rapid-acting insulin?
Regular.
I like that you're guessing though. So Humalog or Novolog are our rapid acting insulin. So when you were looking through, who found it right away? And they were like, this is easy. But it's really important to know that insulin vials look very similar and very standardized. They have very different mechanisms of actions, onset and length. So we want to make sure, even though they look very similar, that we are getting the correct medication. So we'll go over the timelines, but Humalog or Novolog, those are going to be your rapid acting insulins. Then we have our fast acting insulins, which I don't know if I have that on here, but I don't know if I call it intermediate. We're going to ignore that. So fast acting is going to be regular. You guys identify with a regular insulin? I know your guys's are easy because a lot of them say are regular, and a lot of times manufacturers have gotten savvy. They're trying to identify the medications to give you where it's easier to identify. Like if two medicines have very similar names, sometimes they will capitalize like the middle portion of the medicine or something, so you can tell there's a difference from another medicine. Long-acting or basal insulin. Levemir. Oh, you're good. Or what's another one some people have out there? Or Lantus. Yeah, those are two. Levemir or Detamir or Lantus. Those are your long-acting insulin. Okay, we'll talk about the timelines in a minute, but one thing we want to do is make sure that patients know to rotate their sites. If they inject, usually patients, if you're right-handed, you know where they usually like to inject? Their stomach usually, and if they're right-handed, they just want to do their right stomach. But if you continue to inject over and over, you can actually form some scar tissue and have some hypertrophy there, where your fat cells kind of get denser and grow a little bit larger. And actually, if you keep injecting there, it slows down the absorption of the insulin. So you want to make sure we're rotating sites. This little sheet shows basically where you can inject insulin. I know sometimes patients, and when they're in the hospital, they're like, okay, will you get my arm? I have trouble getting my arm. So I like to have people give me my insulin in the arm. when they're giving it to me, because I can't reach that. So it's kind of, yeah, I was like, oh, that's smart, like, way to, you have trouble accessing that site, so somebody else do it for you, you can. You can do your thighs, you can do your buttocks, honestly, you can go more places than this, anywhere you can squeeze up a little bit of fat, you can give insulin. One thing we want to know about insulin that we're going to talk about is the onset, peak, and duration. That's really important because that lets us know when you give insulin or when you give yourself or give your patients insulin, we want to know onset. When does it start to work? And then when is its peak? When is it at its most efficacy? And then duration is how long is it still in your system? Especially for insulins, right? Because like we talked about, people gonna go exercise or do something else. They want to remember when, how much insulin do I have in my system before I go for my run or whatnot. So regimen, we talked about basal and bolus in the homework, meaning that basal, that's that long acting. So they're going to get Levemir or Detamir, usually once, twice a day, most patients, just so it has a little bit of overlap, because even though they're long acting, they don't have a peak that they peak up at. They have a little bit of like onset time. And so if you give 2 doses a day rather than 1, those onset times kind of overlap each other. And then you might have a pump, like my son has a pump, that he's getting, if you remember like the drippy faucet that I talked about with your pancreas, it kind of works that way, where you have an insulin pump that just gives little drips of insulin all day to him. But when he eats, he tells his pump, and then it opens up the faucet, gives him a dump of insulin, and then stops again and goes back to just the little drips. And then we try to avoid sliding scale whenever possible, but sometimes we need it to correct patients' blood sugars, right? If they're high, we need to know how much to give to get them back in order. Anybody given insulin with an insulin pen before? Yeah, you twist it to the number. Yeah, so a lot of times in like nursing homes, long-term care facilities, they'll use insulin pens. Most of the times in acute care, like a hospital, they'll use vials like this. So it just depends on where you work. A lot of patients use the pens. Some of them still use vials as well. So you're going to see both of them when you're out and about. This is a type of insulin pump. I want to say this one is a corded or a tube pump, meaning that this is a little piece. It's kind of like that Dexcom where it injects into the skin. And then one thing I didn't say with the Dexcom, there is a little catheter that's about this long that does inject into the skin. And it's reading actually the glucose that's in your subcutaneous tissue. With the insulin pump, it has this little piece here, injects into the skin, and then it's connected with a tube to this little guy. So that's one downside to these types of pumps, is that they have this little tube, and sometimes you'll put it in your pocket or you carry it, and then they have this thing here that like controls it. My son likes so this is the tubed one. You can kind of see here, this is where it goes into his belly, and there's the tube, and he's holding the little piece. So this is one Omnipod that my son wears. This is a pump that's an all-in-one thing. So he fills it with insulin and then puts it on, and it's good for 3 days. It has enough insulin inside of it. But you can't really see the profile of it. It sticks up about this much. So there have been times where he'll be doing something. He likes to use his legs for his Omnipod, for his insulin pump. And sometimes he'll go by and he'll hit and be like, ah, he like, are you okay? He's like, yeah, I just pulled on my pump, and so because it sticks up farther, you can get it pulled on as well. But those are ones you might see. Onset, peak, and durations. I have a printout that I printed and I forgot to get it on break. I'm going to get it for you, but this one, let me see if I can make this bigger. Oh, good. So the short-acting insulins, or the very short-acting, or the Humalog and Novolog, those they were just starting to produce those when I was brand new baby nurse in nursing school. Isn't that amazing? Like we've got a lot of like new advances in diabetes care. But with those, the onset, they usually start working in about 15 minutes. So my son, because he went to surgery once his A1C to get lower, he's been doing a better job about, he gets his food, or usually he gets his food ready and then he remembers to give insulin. And then he'll give his insulin and he'll wait about 15 minutes, because that's when he can start seeing blood sugar dropping down. Then he'll start eating. Really hard for patients, right? If you're like, I don't want to, I'd rather just start eating now. But you really want your insulin to be peaking at the same time as you're eating. We also have these short acting insulins, which is regular. Regular's onset is about 30 minutes, quite a bit longer. So you can see our patients like my sister's best friend in high school, where that's even longer. If you only have 30-minute lunch break when you're in high school, you've got to remember to bolus before you even leave the class, to go to your lunchroom, to get, your blood sugar or your glucose, the insulin to peak at the time when you're eating, right? It takes a lot of coordination. The faster that we have, where it will peak at the same time as we're eating, the more controlled we're going to be. Intermediate acting insulin, NPH, you guys probably aren't going to see this anymore. It's just essentially they put proteins in insulin to make it last longer. They did that because they didn't yet have the long-acting insulins. So I'm not really going to teach a lot about NPH insulin. It's cloudy because it has the proteins in it. People don't really take it anymore because it's way more effective to have these long-acting basal insulins in addition to either the very short-acting or the short-acting insulins. There is something about drawing up insulins. Occasionally, you will see an NCLEX question or something about drawing up insulin. Essentially, you would give people, like back when I learned how to do this, we would give people regular insulin and NPH insulin. We usually give NPH insulin twice a day, but the onset peak duration, it just really was hard to control blood sugars. But instead of poking people for the NPH and poking them for the regular, you would draw them up in the same syringe. So just, if you can remember, clear before cloudy. You're not probably gonna do it. If you get a question on the NCLEX, just remember clear before cloudy, because you want to get your regular insulin before you get your cloudy insulin. And that's because you don't want any of those proteins to get mixed up into the regular insulin. So that's all I'm going to spend on it. If you get an NCLEX question on it, it's not going to break you because you're not going to use it. And it takes a lot of brain power to remember all the different steps that go. So what I also want to look at is peak. So I call them rapid acting. They call them very short acting. The Humalog, Novolog, peak 1 to 2 hours, which is about right. If you're eating a meal, as you start to eat, as you're digesting it, about 1 to 2 hours is probably when you're going to peak with your meal. The short acting, so regular, 2 to 3 hours, right? A little bit longer. You're going to have that working longer than probably 8. The long actings, they don't have a peak. They start working and then they just stay. They're that tricky faucet, like our pancreas does with our basal. The duration are very short acting insulins, right? 2 to 4 hours. There was one night my son accidentally gave himself way too much insulin and his blood sugar kept going low. And I kept feeding him and snacking him. And it was, I want to say it was hour 3. And he was like, Mom, I can't drink any more juice. I'm too full. I feel sick. I don't want to keep it. And his blood sugar kept going down. So I just went and got sugar. And about every 30 minutes, I would say, open up. And I would pour a little bit of sugar under his tongue because he could tolerate that. And it was absorbed rapidly. It wasn't a lot on his stomach, but it kept his blood sugars up. And then after about another 45 minutes, that duration, the long of that insulin wore off. So that wasn't continually trying to push his blood sugars down. The short acting insulins, 3 to 6 hours. So even longer. So you can see with these durations, like we think it's nice they last longer in some ways, but if you overcorrect or, you have to deal with it a lot longer. And then the long acting, up to 24 hours, really nice. Because it's lasts 24 hours, you want to make sure you give it the same time zone, right? You don't want to take it at 9 o'clock in the morning one day and then 2 o'clock in the afternoon the next day. Sometimes they're given once a day, just at night is typically when they give it. A lot of times they're given BID, morning and night, so they overlap a little bit. Here you can see the peak or onset, peak, and duration. And again, the rapid acting, Humalog, Novolog, Melisapro, those more closely mimic what our insulin increase from our insulin does. This is the NPH I was telling you about, the cloudy. See how it takes a little while to start, and then it comes up, and then it just lasts for a long time. So that's when we usually give twice a day, and before we had this long acting one that acted like our basal insulins. Let's take a quick break. I think we need to move. So let's get into four or five groups. How many do we have? How about you four here, you four in the back, you four. You'll be over here, these four and these four. How many got? 1, 2, 3, 4, 5 groups? Okay, I'm gonna give you guys essentially a order for insulin, and I want you guys to draw out kind of a timeline of what that might look like. Meaning, if you have a patient, so I want you to draw something that's like what was on there, where this is the peak effect and whatnot, and this is the time. So I'm gonna give you something like a little order that will say that patient takes maybe 7 units of Humalog with meals 3 times a day. And they take Lantus twice a day. So I want you guys to write out like, maybe 8 a.m. onto 12 noon, 6 p.m., midnight, and kind of put like Novolog. They take the Novolog, how fast does it work? When does it stop working? With lunch, how does that? So I kind of to draw out what that looks like for your patient. Does that make sense? Yeah, okay, so one person can be here, and then we have 3 spots on the back, not one person, one group. So you guys are actually gonna draw it on the board. It's like you guys are the teachers. So let me give you your things. I'm just gonna pause the So what did you guys come up with? What do we do? Check your vitals. Make sure she's alive, right? We're gonna check her levels. How often are we gonna check her blood sugar?
Like 15 minutes.
How long?
For hours, maybe like 3 hours.
That was a great answer. Why would we check it for about the next 3 hours?
Like that's how long it lasts.
Right, that's how long that insulin is gonna last. Once after 3 hours, it's probably gonna be pretty much out of your system or on the way out. What else are we gonna be doing besides checking? We're gonna notify the provider, right? We're gonna say, hey, this happened. We're gonna be giving her extra sugar or something, right? We might wanna say, hey, I'd like you to have some extra food. I'm gonna give her some proteins and fats that are gonna help keep her elevated a bit longer. Probably give her that full Coca-Cola that she's been wanting for a while. I would.
Yeah, that's what
I mean, do we tell the patient, right? That's a great question. I would, because she's gonna say, "Wait, you've been telling me don't drink all the sugar stuff, right? Or why are my blood sugars going low?" They're gonna wanna know why, right? And so, yes, I would tell them because she has the right to know what her body's experiencing.
So if a patient is wanting bad stuff, junk food, would they just give themselves insulin?
That's what my son does.
I know, I know that sounds bad, but.
I mean, right, is it healthy for you? No, but if you're gonna eat junk food and eat sugar, soda and all that, yeah, you should take more insulin.
Just don't like regular, what are you doing?
Yeah, I know, it's tough. So F.A. Davis says, hey, immediately let the RN know, let the healthcare provider know. Talk about how are we going to give them enough nutrition? They might decide to put them on some IV drip, like something with dextrose in it. Remember D5W or D5NS? That D stands for dextrose. So we might be giving them some IV fluids that have sugar in it to help keep them elevated. We're going to be monitoring frequently. We're going to explain to her what happened and what symptoms to watch for. And then we're going to say, hey, we remember it's rapid acting. So within 15 minutes, blood sugars are going to start, but they might remain low up to 4 hours. And she's in danger of, they call levels. We're not going over the levels of blood sugar. That's low. But then we also want to make sure that we fill out they say medication error report or just an incident report. And just a quick note on incident reports. Has anybody ever had to fill out an incident report? So incident reports, I don't see them as negative necessarily. What I try to do is look at them as, an error happened. And the error could be patient had the wrong medicine, it could be the patient fell, it could be all kinds of things. But usually it's not about blaming the nurse or blaming somebody. It's about looking at the systems that are in place. Because usually for an error to reach the patient, it has to go through a bunch of checks and balances, right? So if this patient had the error, there's usually certain things in place that keep us from giving 10 times enough insulin. And so we'd want to look to see what didn't happen. What of our systems failed? What didn't work? Because that helps you identify holes in your systems or issues. I mean, sometimes it's just the person. So, sometimes a person just says, I'm going to disregard this, right? So that's not safe behavior, but we want to identify that as well. Most of the time, it's a systems issue. Have you guys heard of the Swiss cheese model of when incidents, or it's essentially, you guys know what Swiss cheese looks like? You take a slice and there's holes, right? Well, that's why we have all of our checks, like with insulin, right? We double check our medicine. We pull out the medicine from the Texas or wherever, and we're looking at it, we're checking it, right? And then we're checking it again against the mod. And then we're checking it against our patient, and we're checking the dose. We're doing all these things. We're scanning our patients. We're doing all of these things to help keep us giving the correct medicine. But in an imperfect world, if we have all these checks, if they're all the Swiss cheese with little holes in them, occasionally those holes might all line up together, right? And a hole gets through, or an error gets through all those holes. Hopefully we have all these checks in place that the holes are in different spots, so it'll catch an error from happening. So I say, fill out an incident report, fill out those error reports, because usually we're not looking at it to punish somebody, we're looking at it to see what can we do so it doesn't happen again. I don't want to do the handoff. How would this scenario be different if you gave too much Lantus? So instead of the Lissapro, we gave Lantus. Yeah, we would monitor probably for the full 24 hours. This is when we probably really would have her on some IV dextrose, because it's really hard to keep somebody's blood sugar up for 24 hours, especially when they want to go to sleep and go to bed, and we have to keep waking them up. Okay, so carbohydrate counting. We want to teach our patients to do this, and you're probably going to do this when you're working at facilities, because sometimes they'll say, hey, for every, usually we say 15 grams of carbohydrates. That's kind of a carb choice. So that's kind of the standard we talk about carbs. So say 15 grams of carbs. Or exchanges is another word. They'll say, hey, this person is on a 45 or consistent carb diet, or 45 carbs per meal, something like that. And so sometimes we want to look at and be able to identify where are the carbohydrates in our meal. So if this is our meal that we're serving our patient, where are the carbohydrates here? On the bread. I see the bread, yep. What is the orange juice? I think that's mac and cheese. Yeah. The apple. What is that? Is that banana? I think these are potatoes. right?
Are those fried?
These, I think they're green beans. I think it's chicken and green beans and then a salad. So if each of these, the standard would be, they're probably all about 15 carbs each. So how many carbs do we have altogether here? So 15 plus 15 is 30. This one we probably 45, 60. I don't know if this looks like a whole serving of potatoes, but right, so we want to make sure we know how to identify the carbs. I'd probably say this is about 70 carbs, 60, 70 carbs. It's good to know, right? Because sometimes our patients will say, hey, I want extra cup of orange juice. And I might be like, we only have so many carbs, like we're really trying to keep it consistent. And if they tell me I hate mac and cheese, I'll say, okay, let me give you, I'll take your mac and cheese and give you your juice. You know, we don't want to be consistent with how many carbs they have. Yeah.
So then, like, the one for the big member.
Yeah.
So if the patient doesn't eat all of their carbs and whatever,
You enter it into the glucometer.
okay, and then that will tell you how much it's to get.
Yep.
Okay.
Yep. So glucometer is something that is a system on Epic that you actually will plug in your glucose for your patient, and then you plug in how many carbs they eat, and that will give you a dose of how much to give them. It's really tough though, right? Because we're also like, but wait a second, we want to give the insulin before the meals if possible. Sometimes you just don't know what patients are going to eat or how much they're going to eat. So with glucometer, sometimes you give it after they eat. You'll have a lot of training if you ever use glucometer. So I'm not going to go into a whole lot of that. Here's another example. So what carbs do you see on this tray? The fruit cup, that's probably 1 serving, so 15 carbs. It looks like apple juice to me, but that's a good point. It could be tea, right? If it's an unsweetened tea, then that wouldn't have any carbs. We need to make sure we look, they'll usually have a little ticket that tells you what's there. I think it's potatoes. It's really hard to see. Yeah, so if this is fruit, apple juice, and potatoes, how many carbs would that be? About 45. And that's kind of standard, 45 to 60 for our diabetic patients. We want them to eat carbs, but we also want to make sure they pair it up with some proteins, maybe some fats. And what we don't want them to do is to have 100 carbs in one meal and then, 10 carbs the next meal. It's going to be really inconsistent for them. Unless they're an insulin pump like my son, then he can just say like what he's eating, and that's a lot easier. When we talk about a pre-meal blood glucose, what's a desirable number?
Oh.
All right, and 80 to 130. So we give a little bit higher because they have diabetes, and it's not fasting glucose either. It's just saying before the next meal. That's where we kind of want them to be. Exercise. We talked about a little bit more. It really helps to lower blood sugar. It can help to lower the blood sugar up to 2 days afterwards with a good effect on your system and how your muscles are taking up some of that extra glucose. If you're in ketosis, if you are sick, do not exercise, right? Because what's that going to do to their body? Right? It's going to make it worse. We want to make sure if they are in ketosis, or if they are making ketones. Usually, like if my son's blood sugar has been high and he's not in ketosis, but he's making ketones, I'll be like, dude, you got to go clear those ketones before you can go exercise, right? Because we want your body to be in a space where it's not all of a sudden breaking down extra fats because you're exercising. Carry a fast sugar with you. We want them to do resistance activities 2 to 3 times a week. So like building weightlifting, building muscle of some sort. So long-term complications I want to chat about for a minute. So stroke, heart attack, peripheral vascular disease, Those are macrovascular or like large blood vessels, right? The small blood vessels can be affected as well, the little tiny ones. That's when we talk about like the nephropathy. Remember, what was the number one cause of kidney disease? Diabetes, because it damages those blood vessels. Also can cause retinopathy and trouble with your eyes. Neuropathy, infection, and foot problems. Those are going to be the three biggest issues that you guys are going to see with our long-term complications. So let's play a little game called Name That Neuropathy. So if you have somebody who has numbness and tingling in their feet, is that motor neuropathy, sensory neuropathy, or autonomic neuropathy? Yep, it is sensory neuropathy, right? That numbness and tingling is part of the sensory system. What about if we have weakness in our hands? Yeah, it's motor. It's from weakness in the muscles. And then the next one, I know it's going to be so hard, chronic nausea. Ah, got it. Autonomic neuropathy. So our patients with diabetes, because of just all the neuropathies that they can have, it can affect their GI system and slow digestion. So these patients oftentimes can have a slower digestive process and it's called gastroparesis, right? If it's caused from diabetes, they'll call it diabetic gastroparesis. And it means your intestines, your stomach, they're just slow to move through. So sometimes they'll give them medications like Reglan, which helps to stimulate peristalsis or start moving your bowels, like have everything move through a little bit. So not your bowels like make you poop, but it helps you to have your digestive process works a little bit better. Sometimes diabetic patients that have this will be on long-term Reglan, not because they're nauseous all the time, but to help them with that gastroparesis. Oh, isn't this a pretty picture? My daughter walked by when I was making this and was like, oh, Mom. So diabetic foot ulcers. We've talked a lot about making sure patients look at their feet. They have numbness and tingling. They can have a little ulcer or a wound that can begin. They don't know about it if they can't feel it. So they need to check because those little ulcers, those little wounds can get big, not long. Here's a very typical one that you'll see at the bottom of the foot. You and I would be crying, right? But because of their neuropathy, they don't feel that. And you can see how easily, I don't know if it is yet, but how it can get into the bone very easily. And that's when you have the bone infection, and sometimes even you have to have amputations. No, it's not inevitable, but the big thing is if you can keep your blood sugars controlled, you're going to help prevent neuropathy from forming. If you have neuropathy, if you do good skin checks, then you can prevent having a big infection like this, because you can see when you start forming a blister or something, you'll be able to help treat that. It's the people that don't keep good control of their blood sugars, they have neuropathy, but then they also aren't checking their feet or having good care overall. Yeah.
It can happen by just like if I was like really very get blistered, I don't think I would be able to feel it and then talk like that. Or is the diabetes like eating away at it?
It's not the diabetes that eats away, but you, first of all, you wouldn't feel it, right? Maybe you wore a new pair of shoes because they're cute, and then you keep wearing them because everybody said they're cute, not realizing that you had a blister that formed. And then it keeps getting worse and worse because you're still wearing those new pair of shoes and you don't feel anything wrong. So eventually the skin's wearing away. One of the issues, like we have those macrovascular changes, it impairs the small blood vessels as well. So you're not getting as good blood flow to these wounds. And so it's not able to heal as well because it's not getting all the blood flow it needs. And because we don't feel it, it just keeps getting worse and worse and worse. So usually sometimes we diagnose these because somebody comes in with a fever and we don't know where the infection is, and you take off their shoes and you're like, oh, this has been going for a long time.
Like stitches or something, would they get that local anesthetic or?
For this or for other people?
No, yeah.
Oh. I mean, if they have, I've had patients who I've taken them, I've recovered them after surgery, who've had to have foot partial amputations. And they kind of put them to sleep because it's unnerving to go into surgery, but afterwards they don't really have pain because they have neuropathy. They just don't feel that pain that's in their foot.
You're right. You have them on what is squishy protective shoes. Would they not get it? Like they just kept their.
Yeah, or if they just like there's special shoes that are for diabetics, that are they're not as pinchy. And if they just check their feet, right? If that's why we check their feet every night, and if you see something happening, almost all diabetics eventually also have a podiatrist, a foot doctor that they see. And so they work with that podiatrist to try to make sure they're keeping their feet really healthy. Certain diabetics, they usually have podiatrists clip the toenails because they don't want nursing to clip them. So like, well, if you accidentally like cut them or something, that might cause infection. And so they have podiatry kind of really manage the feet. So you can have beautiful feet as a diabetic, as long as you control your blood sugars and monitor your feet. A lot of patients though, right, it's hard to do over a lifelong condition, especially if they had diabetes for quite a few years, type 2, right? Because the symptoms are rather vague and you can have high blood sugar for years and not realize it. You can have neuropathy that starts before you even are diagnosed. So unfortunately, even if you manage it really well after diagnosis, you could have damage from before diagnosis. Any other questions? Yeah, those are great questions, you guys. I know, gnarly wounds too. So we talked about feet. One thing they say, avoid crossing your legs, which is another one about just trying to have them like not decrease any of the blood flow, right? Want to get good blood flow if we can. Why is smoking cessation so important for these guys? It's okay, you don't have to answer on here, but right, yeah, all of those, when we learned with cardiovascular, it affects all of those things and it just exacerbates all of these complications you can have with diabetes. So surgery, sometimes you're gonna have patients that are undergoing surgery. We want to make sure we're checking their blood glucose a little bit more strict with these patients. Because when do you usually have to stop eating before surgery?
Like, 12.
Yeah, usually 8 to 12 hours you have to stop eating. For diabetics, that might be a little bit tricky because it might be harder to keep their blood sugar under control. So we might keep them on a dextrose IV or just tell them, hey, you can drink, if you start to go low, drink a little bit of clear liquids like apple juice or something to keep you at a good level. Okay, last question. Just type on here, what is one diabetic self-care or education topic in general? If you have a new diagnosed diabetic, what is just one thing you're going to make sure you tell them? Foot. I'm going to say foot to you, and they will know. Oh, don't walk on bare feet. That's really good. Wear a medical bracelet, carry snacks, manage the blood sugar, check your feet. These are really good, you guys. Nice job. Okay, we are done with that. All right, let's really quick. I want to just go over briefly some of the oral medications. I made a little paper for you that everybody should have one. And so I just want to go over some of the actions of oral diabetic medication because they work in different ways. And it's important we kind of know how do they work. So looking at the alpha glucoside inhibitors, those are Fricose or Glycostat. Those are what you might see. And those help to delay the absorption of carbohydrates, right? So if we can delay those carbohydrate absorption, our blood sugar is not going to spike up as fast. That kind of makes sense. But what might be some side effects if we're delaying digestion? Could be nausea. They might have decreased appetite. Maybe acid reflux, yeah, if they're prone to that. So it's kind of knowing what the action is, right? The side effects are usually going to be the opposite of that. So biguanidines, I think I'm saying that right, or metformin, that's really common. We see metformin a lot. They help to decrease the amount of glucose that your liver produces. So it helps to also helps your skeletal muscle to absorb or uptake glucose better. So metformin is pretty common. One thing to know though is when you're on metformin, we're really careful with your kidneys. So remember we talked about with renal issues, if we're going to give a nephrotoxic medication to somebody, like remember we talked about IV contrast being nephrotoxic, I want to be careful with them. Even if somebody doesn't have kidney disease, if they are on metformin and they're going to have IV contrast, that's one where they usually say, hey, don't take your metformin for a couple days. We need to give your kidneys a little break to process all that IV contrast, then restart your metformin. So we don't want to cause kidney damage. That makes sense? That's kind of the big one with kidney damage. So your DPP-4 inhibitors, gliptins, so that might be sitagliptin, sagliptin, excuse me. So they help to increase the insulin production in your pancreas. So you're actually, so see how it's kind of interesting how some of them delay your digestion, others help to increase insulin production. So that's going to help lower your blood sugars. You have your GLP-1 agonists, so probably sounds kind of familiar. Trulicity, Byetta, Ozempic, right? So these are actually diabetic medications. Also found that they help people to lose weight because those help to stimulate the body to produce more insulin. It also helps to curb hunger, right? So that's why we give it to patients who are overweight that maybe want some help with losing weight because it helps them to not be as hungry. And you feel full. Oh, and it also helps to slow your digestion. So you feel full longer and you don't want to eat as much. The SGLT2 inhibitors, like Jardiance is probably the common one that you guys might see. That helps your kidneys from reabsorbing sugar. So you're going to be more likely to urinate out the sugar than to reabsorb it back into your system. So that's kind of a very quick overview of the oral medications. It's always nice to know what your patients are on, like why they're on it, right? Somebody has a big issue with nausea, vomiting, they're not hungry, and it's not because of a weight thing, they're just, maybe they're not really reacting well to their medication. I don't know what it's for. I'm going to, we're not gonna do, actually, you guys tell me, we have 15 minutes, do you want to do a case study or name that patient? Okay, raise your hand if you want to do case study. And raise your hand if you want to name that patient. Okay. Case study it is. All right, so let me get it pulled up. So we're going to work in the same groups that we did the insulin timeline. So you guys are going to answer some questions. So to collaborate with your peers, go ahead and get into your groups.
Wow. Okay, I cannot figure out how to make my case study bigger. So you're going to have to squint or just listen. So I'm going to give you a scenario and then I'll give each group a few questions to answer. So this is actually directly out of your book as well. So Mr. Jones is a 54-year-old banker with type 2 diabetes. admitted to your unit with a tiny red area on his right heel. His admitting blood glucose was 360 mils per deciliter, or milligrams per deciliter. The lesion is so small, you wonder what the fuss is about. While asking about the lesion, you find he wore a new pair of shoes to work all day about a month ago and has been avoiding seeing his healthcare provider about the reddened area. He's placed on IV antibiotics, and within 3 days, the red area has broken open and has yellow drainage. He's sent home with topical antibiotics and crutches to be followed by a visiting nurse. The wound takes 6 months to fully heal. All right, so questions. First group that was right here. Are just 2 of you guys left? Oh, wait, it was you guys? Okay. So list 3 factors for foot problems. And we're talking about patients with diabetes. In the neck, last in the back, why did the sore take so long to heal? Back corner over here, why might topical antibiotics work better than IV antibiotics when he was sent home? Yep, for you guys in the back. Boop, boop, doo. What would have happened if Mr. Jones hadn't sought care? And then in the middle, what team members might you collaborate with to help Mr. Jones? All right, let's go ahead and share our answers. So first group, what are 3 risk factors for foot problems?
Specifically those patients on type 2 diabetes.
Mhm.
His age group is over 40,
Mhm.
and then, we said like their damage for blood will be resolved, but
Mhm.
also then we have a very shoes.
Right. Yep, sounds good. Yeah, he didn't realize it at first. Yeah. Group in the back, why did the sore take so long to heal? Mm-hmm. Mm-hmm. Yep. All right, and then did I ask why crutches are necessary? I think I skipped that one. So anybody, why would crutches be necessary with this guy? Right, we want to keep the pressure off of that foot. Why do you think people might not want to use the crutches? They're inconvenient, they're cumbersome, and it doesn't hurt him to walk, right? But we want to tell them, hey, it's really going to help you heal better if you use these crutches. Okay, why might topical antibiotics work better than IV antibiotics when he goes home? Actually, I asked those guys back here, sorry. What's that? Resources? Mm-hmm. Right, yeah, yeah. You're right, it's directly going to the source of the infection. It's not gonna have systemic negative effects. What was the next one? What would have happened if he hadn't sought care? Yeah, right, like it could go, usually, like the infection will go to the bone, like, and that's when it's really hard to treat. It can take a long time. And then potential amputations. All right, and then what team members might we collaborate with? Everybody, what are some examples? Mhm, mhm. Yes, yeah, yeah, everybody. Yeah. All right, so then for everybody, the nurse documents this description of his wound. Small, red, open area on heel with yellow drainage on dressing. So 2 questions, what is wrong with the charting and how can you improve it? And I want you also to say, what's information is essential to give Mr. Jones for his care at home? Well, you as a group will decide and then, so as a group, I want you guys to, even if we don't have all the information, practice writing a narrative note, right? Let's describe what this wound is. Right, so let's look over the F.A. Davis answers and see how they compare to what we said. So for the risk factors, poor circulation, neuropathy, slow wound healing, there can be more than what's on here. What did he say? Why did it take so long to hear? The poor circulation. And if the blood sugar is high, it might take the white blood cells longer. You might have a delayed response. We talked about crutches, right? We don't want him to bear weight. And then I like what this said too about IV antibiotics. If the circulation isn't very good, even if it's in the bloodstream, it might not be getting to that wound as well as we want it to, all right? Kind of a different way of thinking about that. An unrecognized foot wound can lead to infectious necrosis and even amputation. Mr. Jones might benefit with wound care, dietitian, diabetic educator, home health nurse, healthcare provider for referral to diabetes education center. All right, and so then here, this is what they're saying. That'd be an example of the narrative note. So small red open area on right posterior heel. So she first of all said she's similar, but on the posterior, kind of more specific where it's at. And then we have the measurements of it, of yellow drainage on dressing. In addition, we often are going to include pictures, right? Anybody work in a place or in clinical scene where they take pictures? That's kind of the new standard of care now, because you can describe something, but how I describe something and how all of you guys describe something, we could end up with 25 different descriptions, right? So pictures are super helpful. And then as far as how is he going to take care of himself at home, we want to make sure we know he knows how to take care of his feet, how to change his dressing, how to monitor the wound, when to contact the doctor. He also should we try to make sure he understands why it's important for those tight blood sugar controls. And then work with the healthcare provider to determine what his goals are, right? Because we don't want to say we want your blood sugar to be in control. That doesn't mean anything to him. We want to give him specific numbers of like where we want him to be. That's it. So we're done. Remember to fill out and turn in your KWL test next week. Make sure to do write your own assignment or write your final assignment. And I'll be publishing the study guides later today, so you guys can start studying for the test as well. Thank you guys. Have a good week.